All right, so today I'm pleased to introduce Vadipour. He is a postgraduate year one pharmacy resident at the University of Utah Health. He completed his bachelor's degree in biology at the University of Utah, then completed his PharmD at the University of Utah College of Pharmacy. His areas of clinical interest include primary care and psychiatry, and as a student, he was president of his local College of Psychiatric and Neurologic Pharmacists chapter, and he is currently pursuing a postgraduate year two pharmacy resident position in psychiatry at the Salt Lake City Veterans Affairs Hospital. All right, and I'll pass it off to you.
Cool, thank you for that introduction. So the title of my CE is The Long and Short of Long-Acting Injectable Medications. So we're going to be going over the long-acting medications that are used as antipsychotics, as well as a couple others through the course of this presentation. So myself and my CE mentor, Dr. Anthony May, have no relevant financial conflicts of interest to disclose, and we will only be talking about on-label uses of medications in this presentation. So for learning objectives, we have some for pharmacists and some for technicians. So for pharmacists, by the end, we hope that you can review and discuss the indications, dosing, pharmacokinetics, and the administration pearls for the available long-acting injectable antipsychotics, buprenorphine and naltrexone. And then we'd like you to be able to describe what patients should do when they miss doses of their long-acting injectables, including the buprenorphine and naltrexone, and then demonstrate the understanding of differences in dosing and administration between the different long-acting injectable antipsychotics, and then design a treatment plan for patients utilizing these medications. And for technicians, we would like you to be able to differentiate between the different types of long-acting injectables and the dosing schedules for each one. We'd like you to be able to discuss the benefits of the long-acting injectables, including buprenorphine and naltrexone on patient care, and be able to list the different ones that are currently available. So this is a list of the abbreviations that I will be using through the presentation. And let's get into it. So long-acting injectable medications, these include the antipsychotics that I previously mentioned, buprenorphine and naltrexone, and these are given to patients in order to treat conditions that include schizophrenia, bipolar disorder, and different substance use disorders. So these all do share a major warning for an increased risk of death in elderly patients with dementia-related psychosis. And this is something that is consistent along all of the long-acting injectable medications. So something to keep in mind if you do have elderly patients. Patients do need to trial an oral regimen before switching to a long-acting antipsychotic, so you know that they tolerate it well. And then some of the common side effects of these antipsychotics include EPS, NMS, a prolonged QT interval, torsades, sedation, hyperprolactinemia, leukopenia, neutropenia, and different metabolic syndromes, with some being worse for those outcomes than others. Currently in Utah, the Pharmacy Practice Act does state that pharmacists can administer intramuscular long-acting injectables in either a clinic or community setting once they've been trained to do so. And this training includes a BLS certification and then the attendance of an ACPE accredited training program for administering these medications. But what are the pros and cons of using long-acting injectables? So as far as the pros, these can help with adherence monitoring. Since these have to be administered in clinic, the patients do need to come in and they have face time with healthcare providers. As well, the patient does not need to take a daily medication, so that can help with adherence in patients who may struggle with that. And then this, like I said before, patients will regularly interact with medical staff or their medical team when they come in for their doses. These do lead to more stable plasma concentrations of the drug as well. And there is actually shown to be a lower risk of hospitalization and relapse when you compare these to oral antipsychotic regimens, and they increase the time to first psychiatric hospitalization. In terms of cons, some of them do require oral overlaps that can be complicated for the patient. There is a lack of dose flexibility with almost all of these. One of these injectables that I'll talk about later does have some flexibility, but for the most part, once the patient is injected with the medication, you can't really get it back out. So another thing to be aware of is patients may not count these among their daily maintenance medications. So when you're performing a medication reconciliation, you want to be sure to ask them, are you taking anything injectable that you only get every so often? It can cause injection site reactions. They're often very expensive and therefore unaffordable for some patients. And there are REMS programs associated with some of these, which we'll get into later. To talk a little bit more about the comparison to oral antipsychotics, study was a systematic review and meta-analysis that looked at different randomized control trials, cohort studies, and pre-post studies, with the primary outcome being the rates of hospitalization or rates of relapse with long-acting injectables versus oral antipsychotics. And here they defined relapse as a symptomatic exacerbation or a clinical event that included a hospitalization or increased level of care. So this data was reviewed from 1971 to 2020, so a pretty big range. They looked at 32 randomized control trials, 65 cohort studies, and 40 pre-post studies, which encompassed almost 400,000 patients. And they found that long-acting injectable antipsychotics were actually associated with a lower risk of hospitalization or relapse when they were compared to oral antipsychotics in basically all three of the study types. Moving on, when we're comparing them to usual treatment, which again does include oral regimens, this was another randomized controlled trial that looked at time to first psychiatric hospitalizations in patients with early phase schizophrenia. And so here they defined early phase schizophrenia as fewer than 5 years of antipsychotic medication use. So this data was reviewed from December in 2014 to March of 2019. So again, a pretty large time span. And the intervention was the aripiprazole long-acting injectable, and the comparator was just the clinician's choice of treatment. And this included many different oral options. So when they looked at the results of this study, it showed that use of long-acting injectables actually significantly delayed time to first hospitalization in patients with early phase schizophrenia when compared to usual treatment. And in the long-acting injectable group, it was about 613 days to the first psychiatric hospitalization, but in the usual care group, it was 530 days, so almost 100 days different. And they did find that the number needed to treat was 7. So you can kind of see the background of why we're looking into these long-acting injectables. And as I mentioned earlier with the law, this is something that pharmacists do have a legal right to use in their clinics and practice settings. This is just a list of the available long-acting injectables. I won't go over every single one, but there are some for first-gen antipsychotics, quite a few for second-generation antipsychotics, and then the miscellaneous ones, which are the buprenorphine or Sublocade, and the naltrexone or the Vivitrol that we'll be talking about. So this is our first question. So which of the following of these is not a long-acting injectable? And I will flop over here and give everyone just a minute. Oh, sorry about that. It looks like it closed. Let me open up the polling question. There we go. So let's see if, let's give it a minute to get a couple more responses in. Okay, so we will take a look at these responses. So haloperidol lactate, okay, good job. So I will switch back over to the slides, and that is correct. So haloperidol lactate, oh, sorry, I gotta swap my display again. So the haloperidol decanoate, this is a long-acting injectable medication, as are the fluphenazine decanoate and the Invega Sustenna. The haloperidol, this is the short-acting injectable form of haloperidol. And as you'll see in a little bit, this is not acceptable for use as a long-acting injectable medication. So with that, we'll get into our first-generation antipsychotics, and the first one being the haloperidol. So this is indicated to treat schizophrenia. The pharmacokinetics, the time to peak is about 6 days, and time to steady state is about 3 to 4 months. So it is pretty prolonged. As I go through dosing for all these medications, I won't read every detail. Those are on the handouts and can be reviewed later, but I'd like to just draw attention to a few things on each one. So with that being said, for the haloperidol, you'll notice that initial dose is based off of their oral total daily dose. The dosing interval is every 4 weeks, and there is some oral overlap regardless of which dosing strategy you use. So following the first dose of the long-acting injectable, you want to taper the oral dose by 25% in weekly intervals during the 2nd or 3rd month after starting the decanoate treatment. And just another side note, if the initial dose requires more than 100 milligrams, you need to administer it in 2 different injections with a maximum of 100 for the first, and then the remaining 3 to 7 days later. What's interesting about this medication is you actually have to administer this utilizing the Z-Track technique, and it is only approved for intramuscular gluteal injection. So to Z-Track, as you can kind of see in the picture here, you want to pull the skin and subcutaneous tissue to one side and hold it there. Insert the needle into the patient at a 90-degree angle, depress the plunger to inject the medication into the patient. You want to hold the needle in the skin for about 10 seconds, then withdraw the needle and let go of the skin. As you see, it kind of makes a little depot for the medication so that you don't have it backflow out of the patient. In terms of missed doses for this medication, if you have a patient who is at steady state, who's received a couple doses, and it's been less than 6 weeks, you just want to administer their next dose as soon as possible. If they're not at steady state and it's been between 6 and 12 weeks since a dose, you want to administer the dose as soon as you can and utilize oral therapy if the patient does have recurring symptoms of schizophrenia. If it's been more than 13 weeks, you need to restabilize the patient with an oral antipsychotic and then restart the long-acting injectable when you're able to. As far as safety, this is contraindicated in patients with Parkinson's disease and patients who already display severe CNS depression. And major drug interactions include CYP3A4 and CYP2D6 inducers, inhibitors, and substrates. So this is things like your azole drugs, your rifampin and carbamazepine that can all reduce the concentration of the haloperidol in these patients. Next medication we'll be talking about is fluphenazine. This one is indicated to treat schizophrenia with a time to peak of 8 to 10 hours and a time to steady state of 2 to 3 months. Again, won't go over all the details of the dosing, but dosing interval for this medication is actually every 2 weeks, so it is a little more often than the haloperidol. But once a patient is at steady state, the effects of a single injection may last up to 4 to 6 weeks, but it is still recommended to be given every 2 weeks. Again, this one does require an oral overlap, and you want to taper down their oral fluphenazine or other antipsychotic down by half after the initial injection, and then consider complete discontinuation of oral therapy after you give them their second dose. As far as administration of this medication, it is also able to be given in the gluteal muscle, but intramuscular deltoid injection has also been studied and is appropriate for this medication, but you still want to use the Z-Track technique that I previously talked about for administering this as well. So for missed doses of this medication, you have someone who is at steady state in less than 6 weeks from their last dose, you give them the next dose as soon as you can. If the patient is not at steady state, or it's been 6 to 24 weeks since their last dose, you want to administer the dose as soon as possible with an oral overlap if the patient does have a recurrence of symptoms. The patient should monitor for adverse effects within the first 24 hours of the injection. And then if it's been more than 24 weeks since the last dose, you want to stabilize the patient on an oral antipsychotic and then initiate the long-acting when you're able to. As far as safety, this medication is contraindicated in patients with subcortical brain damage, patients who have a history of severe CNS depression, patients with hepatic impairment, or who are taking large doses of sedative hypnotics. This medication also hasn't been studied in children under the age of 12, so it is contraindicated in them as well. Major drug interactions include CNS depressants and CYP2D6 inhibitors. So these are drugs like fluoxetine, paroxetine, and bupropion. And you can still take the fluphenazine long-acting injectable with these medications, but you definitely want to monitor your patients very closely for fluphenazine side effects as you are increasing the drug concentration. So now we'll be moving on into the second generation antipsychotics, which are more commonly used. So the first one we'll talk about is the aripiprazole monohydrate or Abilify Maintena injection. This one is indicated to treat both bipolar disorder and schizophrenia, but a side note, this is not studied in patients under the age of 18, so it is not appropriate for use in them. The pharmacokinetics do actually differ depending on where the injection is given. It's 4 days in the deltoid and then 5 to 7 days in the gluteal muscle. And time to steady state is about 5 to 8 months. For dosing of this one is going to be given monthly. You need 2 weeks of oral overlap with their oral antipsychotic. And with this one, if patients do have adverse reactions to a higher dose, you can reduce the dose to 300 milligrams once a month. So for administration, this one can be given in the deltoid or gluteal muscle, and there is information in the package insert stating that you must reconstitute the vials and syringes at room temperature. In terms of missed doses, for a second or third missed dose, if it's been between 4 to 5 weeks, you give the next dose. And if it's been more than 5 weeks, you'll administer oral aripiprazole for 14 days with the next injection. So you're basically starting over with the oral overlap. If it's been 4 or more missed doses, if it's between 4 and 6 weeks, you give it to them as soon as possible. And if it's more than 6 weeks, you administer oral for 14 days with the next injection. As far as safety, in terms of warnings, this one may increase the risk of suicidal thoughts and behavior in children, adolescents, and young adults under the age of 24, so something to be aware of. And this can cause cerebrovascular events, including stroke, in elderly patients with dementia-related psychosis. And this is a separate warning than the warning that all of the long-acting injectable medications share for increased risk of death in elderly patients. This one is separate. In terms of drug interactions, as you can see, there are quite a few. This dosing table does show you recommendations for if patients are taking, different strong CYP2D6 or 3A4 inhibitors, what you can do with the dosing. And what I would like to draw attention to here is not all the different dosing changes, but with the lower doses, when you look at like the 200 or 160 milligram doses, they do not make syringes in this size. So if you have patients using these doses of medications, you can only obtain them by using the 300 or 400 milligram vials. So be aware of that. If you have patients taking reduced doses, you usually shouldn't be getting those out of the pre-made syringes. You should be drawing those up from the vials. Next one I'd like to talk about is the aripiprazole Laroxal, or this is the Aristada and Aristada Initio. So this is again aripiprazole, but this one is only indicated to treat schizophrenia. And the Aristada Initio is only used as a single dose to either initiate or reinitiate treatment with Aristada. The pharmacokinetics, both of them have a time to peak of 16 to 35 days. And in terms of time to steady state, Aristada is 9 to 10 months, and the Aristada Initio is 2 to 3 months. You can see here again, there is a lot of dosing on here, but you will base your doses based on what a patient's initial oral dose is. But for the Aristada Initio, as it is a one-time dose, there are no different doses. It comes in a single dose and is not based on a patient's initial oral dose. So this one can be given monthly to every 2 months, and it has 3 weeks of oral overlap if just using the Aristada. But if you're initiating the patient with Aristada Initio, they do not need to take 3 weeks of oral overlap. Instead, they will just take a one-time 30 milligram oral aripiprazole dose. In terms of administration, this one is a little more unique. The deltoid administration is appropriate only for certain doses of Aristada. It's only appropriate for the 441 milligram dose, and it is also appropriate for the Initio. Gluteal administration is approved for Aristada Initio, and then the 662, 882, and 1064 milligram doses of Aristada. And in the instructions for this one, prior to administration, you need to tap the syringe at least 10 times and shake vigorously for 30 seconds to ensure that the suspension is uniform. And you need to repeat this step if the syringe is not used within the next 15 minutes. For missed doses, as you can see here, there is a lot of information again. But what I'd like to draw attention to is that no oral supplementation. As you go up on the dose of the Aristada, you have a larger window when you are not required to give a patient the 3 weeks of oral supplementation. So I'll let you guys look at that for a second. But again, you can use the Aristada Initio to kind of take the place of that oral overlap, as you see on the right. You can give a single dose with the 30 milligram dose of oral aripiprazole if someone is between 7 and 12 weeks of missing their last injection. But again, basically all the time with this medication, if they've missed doses, you just want to administer the next as soon as possible. As far as safety, this one does share that same concern that it can cause cerebrovascular events, including stroke, in elderly patients with dementia-related psychosis. And then as far as drug interactions, based on CYP3A4 inhibitors or CYP2D6 inhibitors, you want to either reduce the dose, or at the lower doses, you do not need to make adjustments, as you see there. The only things I would really like to draw attention to on this slide are that antihypertensives and benzodiazepines, you want to avoid using the Aristada Initio in this patient. The reason for this is that if patients are taking antihypertensive medications, this can potentiate the effect of those medications and cause pretty severe hypotension. And if patients are taking benzodiazepines, this can lead to greater sedation. Looking at the Aristada versus Abilify Maintena, are very similar. They are the same drug, both of them being aripiprazole. The one thing I'd like to say before kind of going through the slide is that no data has actually shown a clinical difference in efficacy between these two formulations. So mostly it's looking at the dosing schedule and the oral overlaps and deciding what's more appropriate for your patient. So like you can see there, the Maintaina is monthly, but the Aristada can be up to bi-monthly. And in terms of oral overlap, Aristada does have a longer one if you're using it, but it does have the Aristada Initio that you can use to make the oral overlap basically just be the one-time dose. The next one we're going to talk about is olanzapine pamoate, or Zyprexa-Relprev. This one is indicated to treat schizophrenia. And in terms of the pharmacokinetics, it peaks within 7 days, and the time to steady state is about 5 months. In terms of dosing for this medication, again, it is going to be based on their target oral olanzapine dose. And then that dose is going to be continued for 8 weeks before you switch over to the maintenance dose. After that, this medication, it's still going to be dosed every 2 to 4 weeks, pending what the patient needs. And there is no oral overlap. So that is one of the benefits of this medication. So this one does have quite a lot more things with its administration and safety that I'll get into. So this can only be injected into the gluteal muscle. And there are specific warnings making sure that the vial is appropriately reconstituted with the instructions in the package insert with no remaining powder clumps before administration. And once the needle has been inserted into the muscle for administration, aspiration should be maintained for several seconds to ensure that no blood is drawn back into the syringe. And if blood does aspirate into the syringe, it should be discarded and a new dose should be prepared for administration. And I'll get into a little more of the details on this, but once the injection is administered, a patient must be monitored in clinic for 3 hours and must be accompanied by someone to their destination when they're leaving. So monitoring for this one in terms of missed doses, if a patient is not at steady state, you want to give the recommended loading dose for 8 weeks. If they are at steady state and it's been less than 2 months since their last dose, give them the next dose as soon as possible. And if the patient is at steady state and it's been more than 2 months since the last dose, you want to give the recommended loading dose for 8 weeks. So kind of re-get them started on that. So in terms of contraindications, this one does not actually have any labeled contraindications. And as far as warnings, this is the post-injection delirium/sedation syndrome. And this is the reason that a patient needs to stay in the clinic or administration site for 3 hours after administration, and then make sure that they have someone else taking them home and someone who can monitor them. So this is actually a REMS program that is active for the medication, but when I say active, the FDA since March of 2020 has kind of put a hold on all REMS programs, saying that you don't need to be actively updating this. But that's likely not something that's going to continue for too much longer, and there is a chance that they get reinstated. So all parties involved have to be REMS certified, and that includes, the prescribers, the pharmacy, the person administrating, and then the patient as well. So again, this one does share that same cerebrovascular events, including stroke warning in elderly patients with dementia-related psychosis. And big drug interactions for this one are your CYP1A2 inducers and inhibitors, and then CNS depression and antihypertensive agents. So your CYP inducers are going to be things like carbamazepine or rifampin. So these, you might have to increase their dose of the Zyprexa-Relprev. For the inhibitors, things like ciprofloxacin or fluvoxamine, you'll want to lower your dose. And then with the CYP2D6 minor inhibitors, I didn't put it on the slide just because it isn't as big of an interaction, but it is one that exists and one to be aware of, but usually doesn't require any sort of dose changes. And similarly, the CNS depressants can increase sedation, and taking antihypertensives with it can increase the risk of hypotension. This is our second audience response question. So SM presents to your clinic to initiate therapy with a long-acting injectable antipsychotic. She is currently well controlled, taking olanzapine 20 milligrams daily. Which of the following things should you consider prior to administration of the olanzapine long-acting injectable Zyprexa-Relprev injection? And let me move over and pull everywhere here, and we'll go to the next question. Okay, I'll just give everyone a minute to take a chance and read those. So the answers: does the patient have someone to accompany her when she leaves? What other medications does the patient take? and making sure that the patient has at least 3 hours to remain in the clinic after the injection, or D, all of the above. So looking at the responses, great. D, all of the above is the answer. So you want to keep track of all of these things. So this question doesn't really have a wrong answer, but there are ones that, but it is something that you need to be looking at multiple different things before you give this to a patient. So great job. And let's go back over here. Okay. So like I said, all the above answers are correct and all should be considered in this patient. So the next medication we'll be talking about is paliperidone palmitate. And this comes in 3 different forms that I'm going to be talking about at the same time. So the first one is the Invega Sustenna, the second one is the Invega Trinza, and the third is the Invega Halfiera. So all of these are indicated for the treatment of schizophrenia, but the Invega Sustenna is also indicated to treat schizoaffective disorder. So the pharmacokinetics, the time to peak of the Sustenna is 13 days, whereas the Trinza and Halfiera are both closer to 30 days. The time to steady state of the Sustenna is 4 to 9 months, of the Trinza is 14 to 24 months, and of the Halfiera is 24 to 27 months. So we're going to be going over the dosing of each formulation separately. We're going to start with the Sustenna. So for Invega Sustenna, what I'd like to draw attention to is that you give an initial dose on day 1, and then on day 8, you'll give a second dose, which is reduced, and then you'll move to maintenance dosing. The dosing interval for this medication is monthly. And again, this is another one that doesn't have an oral overlap. As far as the Invega Trinza, this one is actually going to be a 3-month injection. So the patients only have to get this once every 3 months. There's no oral overlap, but the caveat is that you can start a patient on this after they have been stable on the Invega Sustenna for at least 4 months. And you'll base your initial dose on what their Invega Sustenna dose was. And then moving into the Invega Halfiera, you can start this after a patient is stable on the Sustenna for at least 4 months, or if they were stable on the Invega Trinza for at least 1 3-month cycle. And what you'll notice about this one is that this, again, does not share an oral overlap, but it is a once every 6 months dose. So patient only needs to come in and get this twice a year. So talking about the administration of the Sustenna, which is the 1-month formulation, this one you can only give into the deltoid muscle for the initiation doses that are given on day 1 and then day 8. The maintenance doses can be given in the deltoid or gluteal muscles. And again, this one is specific about shaking the syringe for at least 10 seconds prior to injection. As for the Trinza, which is the 3-month formulation, you can give this one into the deltoid or gluteal muscle. This one is specific that you have to shake the syringe with the tip pointing upwards for at least 15 seconds prior to administration, and that it should be administered within 5 minutes of shaking. For the Halfiera, this one can only be given in the gluteal muscle. And again, you want to shake the syringe with the tip pointed upwards very quickly for at least 15 seconds, and then it says to rest briefly, then shake again for 15 seconds for a total of 30 seconds. Your final solution should look uniform, thick, and milky white, and again, must be administered within 5 minutes of shaking, but this one is a little different that you have to inject it over 30 seconds. It's not like the others where you just go in and inject it. In terms of missed doses, based on which dose it is, whether it's a maintenance or a second initiation dose, meaning the dose that would normally be given on day 8 for the Sustenna, here are the instructions for those. It just, again, depends on what time, how long it's been since the last injection. There are recommendations for if it's been less than 4 weeks, between 4 to 7 weeks, or if it's been greater than 7 weeks. And then for the maintenance dose, between 4 to 6 weeks, and then 6 weeks to 6 months, and greater than 6 months. For the Trinza missed doses, what I want to bring attention to is for a lot of these, if the patient has missed them, if it's been 4 to 9 months since their last dose, you do need to reinitiate them with Invega Sustenna. So you do have to go back and then re-get them onto the Trinza. And then again, if it's been greater than 9 months, you have to completely restart them with the Invega Sustenna and make sure that they tolerate that for 4 months before moving back to the Trinza. As for the Halfiera, this one obviously has a little bit longer windows in between when you missed the last dose and what you need to do if the patient has missed it. So it's between 6 months and 3 weeks, up to 8 months. You can see that you can kind of start with the Invega Sustenna and then go back to the Halfiera. If it's been between 8 and 11 months, it's still a similar process where you start with Sustenna and go to Halfiera. And if it's been greater than 11 months, you're going to reinitiate treatment with the Invega Sustenna, and then you can reinitiate the Hafyera after they've been stable for 4 months. So if the patient is missing this consistently, you kind of always have to go back to giving them the monthly injection before moving them back on to the other ones. As far as safety, these medications actually are one of the few that do have a contraindication if a patient has reduced renal function. These specifically do state a creatinine clearance of less than 50 mils per minute is a contraindication. And again, they share this warning that they can cause cerebrovascular events, including stroke, in elderly patients with dementia-related psychosis. Again, major drug interactions include CYP3A4 inducers such as carbamazepine and rifampin, and then CNS active medications and medications that can cause orthostatic hypotension. So again, CNS active medications, these can cause an increased sedation effect, and they do potentiate the effects of other medications that can cause orthostatic hypotension, And in patients who are taking strong CYP3A4 inducers, such as carbamazepine, they actually do recommend that you avoid use of the long-acting injectable medication and consider switching to oral paliperidone. Here, the renal dose adjustments are on this chart. So you can see that it's kind of divided up into, greater than 90, 80 to 90, 50 to 80, and then less than 50. And what I'll draw attention to is with the Invega Hafyera, if a patient has anything below a clearance of 90, you should not use this medication. And then once, like I said before, once a patient gets under a clearance of 50, the use of any of these is no longer recommended. We'll go to our next audience response question. So which of the following paliperidone formulations can only be administered in the gluteal muscle? Option A is Invega Hafyera, option B, Invega Sustenna, and option C, Invega Trinza. I'll move back to the instructions here, and I'll just give everyone a minute to put in some responses. Okay, so looking at the responses, you guys are correct. The Invega Hafyera is the one that can only be administered in the gluteal muscle. So something to keep in mind for your patients if you choose to go this route with their treatment. Okay, so like I said, the Invega Sustenna initial dose should only be administered in the deltoid, and then other doses can be given in either the deltoid or gluteal muscle. And for the Invega Trinza, it can also be given in the deltoid or gluteal muscle. So great, the Hafyera is the only one that can only be given in the gluteal muscle. The next one we're going to talk about is risperidone or Risperdal Consta. So this one is used for the treatment of schizophrenia and bipolar 1 disorder. And in terms of the pharmacokinetics, it peaks within 8 to 24 hours, and time to steady state is between 15 to 30 days. So here you can see that the doses are pretty similar, whether you're treating schizophrenia or bipolar disorder, but the dosing interval of this one is every 2 weeks, and it does require a 3-week oral overlap when you're starting this medication for a patient. In terms of administration, this one can be given into either the deltoid or gluteal muscle, and you must shake the vial vigorously once the diluent is added, because this does come in the form of microspheres. So you have to make sure that those are appropriately suspended before you give this medication to the patient. It is recommended to give within 2 minutes of shaking it and mixing it together, and then you can resuspend it by shaking if necessary. For missed doses of this medication, if a patient is not steady state, it's been less than 2 weeks since their last dose, you want to give the next dose as soon as possible with 3 weeks of oral overlap. If the patient is at steady state and it has been less than 6 weeks since their last dose, you can give the next dose as soon as possible, and they do not require an oral overlap. But if a patient is at steady state and greater than 6 weeks since their last dose, you want to make sure that they're getting that 3 weeks of oral overlap with the dose. So again here, if it is less than 6 weeks since the last dose and they're at steady state, they don't need an oral overlap. Otherwise, they will need one. In terms of safety, again, shares that same warning that it can cause cerebrovascular events, including stroke in elderly patients with dementia-related psychosis. And then it shares similar drug interactions to the others with CYP3A4 inducers and CYP2D6 inhibitors, which for the inducers, again, things like rifampin, you want to decrease the concentration of the risperidone. And for the inhibitors, things like fluoxetine and paroxetine, you want to increase you want to decrease the dose of the medication to get an increased concentration. Or excuse me, the medications that are CYP2D6 inhibitors increase the risperidone concentration, so you want to decrease their dose. This will be our next response question. So JD presents to the pharmacy distressed that he missed his last dose of his risperidone long-acting injectable. He received his last dose of Risperdal Consta 5 weeks ago and has been consistently receiving injections for the past year. How would you reinitiate his long-acting injectable therapy? Option A is give the next dose as soon as possible with 3 weeks of oral overlap. Option B, give the next dose as soon as possible with no oral overlap. And option C, give the next dose as soon as possible with 6 weeks of oral overlap. I'll just give everyone a minute to put in their responses while I switch over. Okay, so let me take a look here at the responses. Okay, so we have a split between A and B, with some people putting A, and now it looks like it's getting more towards A. So actually on this question, B is going to be the correct answer, and I can go over why that is. So B is the correct answer in this case because the patient has been taking the Risperdal for the past year. We would count him as being at steady state. And since it is less than 6 weeks since his last dose, since he said it was 5 weeks ago, we would say that he does not need any oral overlap per the manufacturer instructions. And then as far as the other two answers, giving the next dose with 3 weeks of oral overlap, because he is within 6 weeks of his last dose, no oral overlap is actually required because, again, he's at steady state and it's only been 5 weeks. Giving the next dose as soon as possible with 6 weeks of oral overlap is also inappropriate because there are no indications for this medication that requires 6 weeks of oral overlap. It is either 3 weeks or none. Great job. So the next one is another form of risperidone, or called Perseris. So this one is for the treatment of schizophrenia, so it does not share that bipolar disorder indication that the Risperdal Consta does. As far as the pharmacokinetics, it has a peak within 4 to 6 hours, and then a second peak within 10 to 14 days. The time to steady state is between 45 to 55 days. And then looking at the dosing for this one, unlike the other form of risperidone, this one is given monthly and does not require an oral overlap, and again, is going to be based on your patient's oral risperidone dose. As far as administration, this one is only given subcutaneously in the abdomen, and it is specific that the medication must come to room temperature prior to preparation. So this medication technically does not fall under the law for Utah pharmacists. That one is specific that you are giving these IM injections, but this is a subcutaneous injection. I did want to go over it because there is a chance that the law could be expanded to include these, similar to the other medications, but currently this is not one that would fall under it. If the patient misses the dose, this one's really simple. You just give them the missed dose as soon as possible. And as far as safety, this one doesn't really have any contraindications or warnings, but it does have interactions with CYP3A4 inducers and 2D6 inhibitors, similar to the other form. Next medication I'd like to talk about is buprenorphine, or Sublocade. And one thing that I will say, this one also does fall into that window of being given subcutaneously. So it does not fall under the current law here in Utah. But again, there is potential that that could change in the future. So this one is for the treatment of moderate to severe opioid use disorder in patients who have initiated treatment with a buprenorphine-containing product, followed by dose adjustments for a minimum of 7 days. So patients who have already been using buprenorphine. It peaks within 24 hours, and time to steady state is between 4 to 6 months. As you can see here, this one also has a different initial dosing strategy where you give 300 milligrams at first, and then for the second dose, you can give either 100 or 300 milligrams. So for patients who still experience cravings or withdrawal symptoms, even if their transmucosal buprenorphine dose isn't as high, so that you would think their second dose will be for 100 milligrams, if they're still having bad withdrawal or cravings, you can increase the second dose to 300 milligrams. So again, we're going to be basing this off of their buprenorphine dose. And then maintenance dose is 100 milligrams either way. This is dosed monthly, and there is no oral overlap of buprenorphine with this. And a side note for this one is that for patients who are taking 100 milligrams once a month, there might be instances, for example, if a patient is going on an extended traveling trip where they won't be able to get their maintenance dose every month, you can give a single dose of 300 milligrams to cover a 2-month period. Again, like I said before, this one is only given subcutaneously in the abdomen, and it is recommended to allow the medication to come to room temperature before administration. But one of the really unique things about buprenorphine or the Sublocade is that in the event the depot must be removed, it can be surgically removed under local anesthesia within 14 days of injection. And this kind of sounds weird, but the reasoning is because that when this medication comes into contact with a patient's bodily fluids, it actually does form a solid depot. So it is kind of cool that if there is any reason you need to remove this, it can be removed within 14 days of first being administered. So if a patient does miss the dose, you want to administer their next dose as soon as possible. And occasional delays in dosing up to 2 weeks are not expected to have a clinically significant impact on the treatment effect, as long as the patient has already been stable on the medication before. So again, like I said earlier, this medication does form a solid once it comes into contact with a patient's bodily fluids. And so this means that it carries a REMS program or a REMS warning. And like I said before, currently REMS programs are kind of on hold, but that probably won't last forever. So this REMS program is for risk of serious harm or death if the medication is administered intravenously. So you have to make sure that this is always administered subcutaneously, because again, you don't want to be creating a solid in a patient's veins. So again, it can only be directly supplied to a healthcare provider for administration by a healthcare provider, and everyone involved in handling the medication has to be REMS certified. This one has quite a few drug interactions with benzodiazepines, CYP3A4 inhibitors and inducers, different HIV medications such as the protease inhibitors and non-nucleoside reverse transcriptase inhibitors, with muscle relaxers, serotonergic medications, diuretics, and anticholinergic drugs. So the main side effects of buprenorphine or Sublocade are respiratory and CNS depression, neonatal opioid withdrawal syndrome. So you want to make sure that you know if your patient is pregnant when starting, adrenal insufficiency, opioid withdrawal, hepatitis, jaundice, orthostatic hypertension, a prolonged QT, and an elevation in cerebrospinal fluid pressure. And the last medication we're going to talk about is Vivitrol, or naltrexone. So this medication is indicated to treat alcohol dependence and to help prevent relapse to opioid dependence. So this one also has 2 separate peaks. It's about 2 hours to the first one and 2 to 3 days to the second one. And the time to steady state is between 25 and 50 days. This one, dosing is super straightforward. The initial dose, maintenance dose are both the same, and this one is dosed monthly with no oral overlap. This one can only be given in the gluteal muscle, and again needs to be allowed to reach room temperature before administration. And there is a note on this medication that once it's prepared, you have to administer it pretty quickly, as it does thicken up. So if someone misses a dose of this one, again, super simple, give them the next dose as soon as you can. Contraindications for this medication are patients with either hepatitis or liver failure, patients taking opioid analgesics or who have a physiological opioid dependence, and patients in acute opioid withdrawal. And a specific warning for this medication is that a patient should be opioid-free at the time of dose initiation. Again, major drug interactions include opioid medications, and then major side effects include hepatotoxicity, precipitating opioid withdrawal or overdose, and then eosinophilic pneumonia, depression, and suicidality. So this is one that you would want your patients to be carrying something like a wallet card, just to say that, hey, I am taking naltrexone or the Vivitrol long-acting injectable. So in case the patient needs emergent surgery or another intervention that would require opioids, the patient can get an increased dose of opioids, or it can be managed by the primary team taking care of that, knowing that the opioids they're taking may not have as much effect with this medication. And then in terms of the overdose, it's not so much that the medication itself causes opioid overdose, but because there's opioid blockade in the patient's system, patients may try to use higher doses of opioids to overcome that blockade. So in summary, I won't go through this whole slide, but if you take nothing else from this presentation, this slide gives you a quick summary of which medications there are, if they require an oral overlap, any sort of unique administration pearls, and any specific notes that I went over as we went through. With that, we'll do 3 more questions and then I think we'll be done. So the first question is, which of the following medications does not require an oral overlap? And I will give you guys a second to answer here while I switch over. Okay, so it looks like the 2 answers that people had are the risperidone consta or the olanzapine pamoate or the Zyprexa relprev. So for this one, B is the correct answer. The olanzapine does not require an oral overlap. Aripiprazole or Abilify Maintena does require 2 weeks of oral overlap. The flufenazine does require a dose taper to get the patient off of their oral medication. And the risperidone or Risperdal Consta does require 3 weeks of oral overlap when first initiating treatment. The olanzapine or Zyprexa relprev is one of the ones that does not require an oral overlap, similar to paliperidone. Next question, so which of the following LAIs is administered every 3 months? Okay, and we'll look at the responses for this one. So perfect, everyone got it. So the Invega Trinza is one that is given every 3 months. And something that I maybe should have drawn a little more attention to earlier is that with the 3 different Invega formulations, the 3 and 6 months, the names kind of give it away. Trinza, Tri, 3. And then for the Halfiera, it's every 6 months, every half a year. So clever naming on their part. For this question, the aripiprazole monohydrate or Abilify Maintena, this one is given every month. The risperidone consta is given every 2 weeks. And the Zyprexa relprev is given every 2 to 4 weeks. So again, B, paliperidone, palmitate, or Invega Trinza is administered every 3 months. And so the last question I have is, which of the following is true? A, being that long-acting injectable antipsychotics decrease the time to first psychiatric hospitalization. B, long-acting injectable antipsychotics increase the time to first psychiatric hospitalization. Or C, long-acting injectable antipsychotics are often inexpensive. I'll give everyone a minute to submit some answers here as well. Okay, so we had a split here, but B is going to be the correct answer here. So I know that A kind of sounds like it could be the answer, but like in that study that I kind of presented at the beginning, long-acting injectables have been shown to increase time to first hospitalization, not decrease the time. So it's usually a longer period in between. And the difference from the study that I referenced was about 100 days, give or take a little bit. And then answer C, long-acting injectables are often expensive and can be very cost prohibitive for a lot of patients. So B is the correct answer because long-acting injectable antipsychotics have been shown to increase the time to first hospitalization, and then as well, they have been shown to reduce hospitalization and relapse rates. With that said, I'd be happy to take any questions, and let me